I would like to thank the organizers, Dr. Matthew John and his team, as well as I'd like to thank the chairpersons for the kind words. And I'm just talking about a disease which I think many of the endocrinologists and physicians who are managing diabetes really know about it, and is actually poorly reported. So I just want to start with a case, and this is a story of a male of 57 years, and we were called into the surgery ward for a gastro consultation, and this man had a history of melena, and this is a are you able to hear me?
Yes.
Yeah. This man has presented to the surgical ward with a history, suggestive of cellulitis of the left leg. He is a diabetic, and we were called in for evaluation of melena. He is not an alcoholic, and there is no history of any risk factors for liver disease in the past. He is a diabetic type 2 for 15 years and was on mostly on oral hypoglycemic agents, and in between he had history of intake of insulin as well. He is a hypertensive. He had an ischemic heart disease, which was actually, he was only on medical therapy because his angiogram did not show any critical stenosis. And on physical examination, he had edema, mild, he had moderate ascites, he had minimal jaundice as well. He had the presence of hepatic flaps in the form of grade 2 hepatic encephalopathy, otherwise he was reasonably conscious. On examination, he had a significant cellular in left leg. On his workup, we found that he has got mild hyperbilirubinemia, and he had moderate elevation of transaminases, slightly more on the AST side, and gamma GT was also slightly increased. His INR was prolonged. He had a high blood sugar with a high HbA1c, suggesting probably he was not reasonably controlled. Renal functions are normal, but sodium was slightly on the lower side. He had mild anemia, and his viral markers were negative, and alpha fetoprotein was 11.2. We did an iron profile, which was also negative, especially, but the ferritin was slightly on the higher side. Ultrasound abdomen showed features suggestive of cirrhosis of liver, splenomegaly, and he has got moderate ascites and a small soil in the liver in the right lobe. So we took him for an ultrasound guided aspiration of the ascitic fluid, which actually showed features of spontaneous bacterial peritonitis, but the culture was negative. Probably he was on some antibiotics for the cellulitis. He was shifted to the liver ICU and he was managed accordingly. After stabilizing, he was taken up on an upper GI endoscopy because the bleeding was continuing. It showed a grade 3 esophageal varices with evidence of signs of recent hemorrhage, and he underwent endoscopic variceal ligation. After this, he was taken up for a CT because he had a liver lesion, and which actually showed cirrhosis of liver with an soil in the segment, the right lower liver, suggestive of hepatocellular carcinoma. This is actually the liver showing a tumor in the right lower liver. So coming to our case, this man has got, according to the gastroenterology perspective, he has got decompensated cirrhosis of liver, portal hypertension, with a history of upper GI bleed and early hepatic encephalopathy, and incidentally detected hepatocellular carcinoma, presence of spontaneous bacterial peritonitis. He is child C, MELT 25, and his etiology is probable NAFLD. And he also has a cellulitis left leg with the underlying type 2 diabetes mellitus, hypertension, and CAD. His VMA was 30. So in other words, we are seeing a patient here who did not have any history of liver disease. He was never diagnosed with liver disease, and actually he came with a complicated liver disease in the first time during the course of his management. So where is the problem? Are we underdiagnosing, underreporting? Are we not looking for this? Because this man has got all the, he has gone into all the spectrum of liver disease which can occur in NAFLD. So when you look at the liver cirrhosis, where diabetes is associated, where diabetes is common, one is that, as you know, it's hemochromatosis. Hepatitis C virus is associated with the high incidence of diabetes, and so-called cryptogenic cirrhosis. Now we know that many of them are actually NAFLD, and then even in alcoholic liver disease, the incidence of diabetes is slightly more. And of course, the more common and the garden variety of NAFLD leading on to diabetes. But what will be the cause of this? When you have a combination of cirrhosis and diabetes, the mortality of cirrhosis and the morbidity associated with diabetes increases. And the worst thing is that once you have diabetes, in a patient with chronic liver disease, the chance of them developing a hepatocellular carcinoma is much more. So you know that NAFLD is the most prevalent form of CLD in the world today. And earlier it was hepatitis and alcoholism. Now this has become the more common cause. And almost it parallel to the epidemic of obesity and type 2 diabetes mellitus. So when you come to the entity of NAFLD, you know it's a non-alcoholic fatty liver disease. And it is associated with many other diseases, which I will come to it later, and becomes a part of metabolic syndrome in certain cases. And what is the source of the fat that accumulates in the liver? Majority of the fat TGL is actually from the circulating free fatty acids, almost 50 to almost 60% of it is that. So coming to the terminals of NAFLD, we have steatosis, or you have steatohepatitis. So once you develop NASH, non-alcoholic steatohepatitis, that becomes a very important thing, because almost 1/3 to 40% of them lead on to cirrhosis of liver, lead on to fibrosis, which ultimately lead on to cirrhosis. So we have to catch hold of them in between before they go in for cirrhosis. So NAFLD can have liver-specific diseases like cirrhosis, HCC, or it can have extrahepatic disease as well. You know that NAFLD has got high incidence of diabetes mellitus. NAFLD has high incidence of cardiovascular diseases, and also on a high incidence of CKD, especially in patients with diabetes. So when you look at the progression of NAFLD, you know that from just steatosis, one group can progress into steatohepatitis. Why somebody moves into steatohepatitis, which we are not very sure, there are many factors involved in that. But unfortunately, if somebody goes into NASH, then there is a likelihood that this person, nearly 40% of them lead on to fibrosis. And fibrosis occurs in a gradual fashion, but in NAFLD, when they have got diabetes, the fibrosis progresses fast. Similarly, the chance of developing hepatocellular carcinoma also increases more. So you got NASH with early fibrosis, then advanced fibrosis, and then finally you have and then HCC. So when you look at the cirrhosis, CLD and NAFLD, sorry, cirrhosis can be an effect of diabetes mellitus, or cirrhosis can be a cause of diabetes mellitus. Earlier we know that the terminology of hepatogenous diabetes, and when you look at the pathophysiology of NAFLD, and especially in diseases with metabolic syndrome, and that true in diabetes, type 2 diabetes mellitus, there are so many mechanisms by which the liver accumulates fat, and it can be different reasons, and even now we know that intestinal microbiota is also partly responsible for that. So whatever be the cause, ultimately the fat in certain group, it can lead on to inflammation. That inflammation will ultimately lead on to fibrosis as a reparative process, and this fibrosis can lead on to advanced fibrosis and nodule formation, leading to architectural changes in the liver and converting this into cirrhosis, and with all those complications of cirrhosis, including portal hypertension, and on long term they can get hepatocellular carcinoma. So when you look at the diabetes and NAFLD, you know that in NAFLD, diabetes patients, you know, almost 70% has got NAFLD. But in those patients, even in asymptomatic patients, if you do a liver biopsy in type 2 diabetes, then it is found that even with a normal LFT, 20% can have NASH. So there are different geographical variations regarding that. So when you look at diabetes mellitus as a complication of cirrhosis, that is so-called, previously people used to call it hepatogenous diabetes. I don't know whether endocrinologists agree to that. And glucose intolerance can occur in 60 to 80% of patients with cirrhosis liver, and diabetes develops, when you analyze patients at a time, diabetics have got nearly 20 to 60% depending upon different studies. So how these people develop, cirrhotics develop diabetes, there are many reasons on that. I'm not going to details of it, but there are hepatic factors, there are actually insulin resistance related factors, and glucagon and other hormones involved in that. So coming back to NAFLD and diabetes, we know that NAFLD increases the risk of diabetes almost to 2 to 5-fold. And it also, not only it increases the incidence of diabetes or prevalence of diabetes. It also increases the diabetes complications. And diabetes, in other words, diabetes can actually increase the risk of NALP progression also, which I have already told you, because diabetes studies have shown that those who have diabetic as well as have a fatty liver, and even non-fatty liver disease like hepatitis B, C, in all diseases, diabetes as a cofactor or a comorbid illness can increase the or worsen the liver status. So in other words, coexistent NAFLD and diabetes more severe adverse outcome than as a single disease. So looking at the different epidemiology studies linking diabetes and cirrhosis, diabetes and hepatic fibrosis, the reason could be many, but they found that presence of insulin resistance or high blood sugar lead on to this formation of hepatic fibrosis. And diabetes and prognosis of cirrhosis actually affects the prognosis. And it is found that patients with diabetes got a poor prognosis in cirrhosis as well, greater risk of complications, then the higher diabetes mellitus related mortality, especially they die due to non-diabetic complication like hepatocellular failure. So other biological mechanisms you look at in patients with diabetes and cirrhosis, it is, as I told you, that why they develop fibrosis, because it is found that they got a high incidence of inflammation as we see in NASH. And it's also, it exacerbates the existing liver failure, so it actually worsens them. And diabetes, because of a disease which can enhance the possibility of infections, diabetes or cirrhosis also, it's like that. So the chance of infection is much higher in these patients. And once they get a cirrhotic with this diabetes, if they develop an infection, the mortality is increased. So when you look at the different types of cirrhosis and what is the influence of diabetes on this, and it's found that even in patients with non-NAFLD, like hepatitis C virus, alcoholic liver disease, and hepatitis B virus, there is exacerbation of fibrosis and progression of liver disease. And what about drug therapy? As we know that most of the drugs used in diabetes are metabolized in the liver, and metformin were initially used for treating fatty liver, and drugs like pioglitazone, rosiglitazone also been tried for NAFLD. The newer drugs, the data is emerging, which needs to be looked at. So coming back to diabetes mellitus and CLD, there is an increase for threefold risk of mortality from cirrhosis. And diabetes mellitus and cirrhosis mortality is related to both viral and non-viral related etiology, which I already told you. And an Asian study which has shown that even in those patients who have got a low BMI, the risk is high. That is because of the cirrhosis related, or diabetes mellitus and cirrhosis, the related J complications or hepatologic complications are more. So looking at a study, which is a very elegant study, which actually looked at high prevalence of undiagnosed cirrhosis of liver with an advanced fibrosis in type 2 diabetes patients. It is found that they have got significant rates of NAFLD, fibrosis, and cirrhosis. So all the spectrum of NAFLD related disease is more in patients with diabetes mellitus. It's also an Asian study which also looked at the various risk factors of the liver disease leading on to fat as well as for fibrosis. Both were found to be significantly high in this group. So coming back to our diabetes mellitus and NAFLD, you know that type 2 diabetes mellitus with the comorbidities like obesity and hyperlipidemia are the high incidence of leading on to NAFLD, which can ultimately lead on to cirrhosis and hepatocellular carcinoma. And studies have shown that there is 2 to 5-fold increased risk of cirrhosis in type 2 diabetes mellitus. And it's also categorically shown that diabetes mellitus in cirrhosis is a risk factor for hepatocellular carcinoma. So how to monitor in your practice in patients for liver disease? I know that when your practice, you will look for liver disease, kidney disease, heart disease, neuropathy, etc., etc. But no, I think you have to put liver also into your target, and you should deliberately evaluate for liver disease, work up for etiology of liver disease like viral markers, metabolic or autoimmune nephropathy if you have evidence of liver disease. And liver function test at least should be done once in 6 months if there is any abnormality on that. And if there is platelet count comes down, there is an early suggestion that this patient is going in for chronic liver disease or fibrosis. Try to do an ultrasound abdomen earlier at the beginning itself, and if there is any evidence of fatty liver, try to do it once in 6 months or 12 months at least. If there is evidence of significant fatty liver, try to do a fibroscan or a shear wave elastography, which is easily available at least once in a year. And liver biopsy needs to be done only in study protocol or when there is a differential diagnosis like autoimmune hepatitis or hemochromatosis, etc. This is actually a non-invasive test for liver fibrosis, an excellent tool, and shear wave elastography, which is freely available and gives a lot of information on liver fibrosis. So when you want to refer a patient to a gastroenterologist or a hepatologist, if you have detected a significant liver disease, like significant fibrosis on a shear wave, or he has got evidence of chronic liver disease, and complications of NAFLD like cirrhosis of the liver or HCC. And other complications of cirrhosis of the liver like GI bleed, ascites management, and hepatic encephalopathy, etc. And one small note which I have noticed is that when there is recurrent hyperglycemia in a diabetic, if you cannot identify any obvious cause, think about liver disease like cirrhosis, especially hepatocellular carcinoma. So, ladies and gentlemen, I would like to conclude my talk by telling that there is a strong feeling that there is an underreporting of CLD in diabetes patients, especially type 2 diabetes. There is a high association of NAFLD and diabetes type 2. Diabetes mellitus increase morbidity and mortality of liver cirrhosis, and also diabetes mellitus, especially the type 2 variety, has got an increased risk of HCC. And also please note that presence of liver disease can deregulate the control of diabetes. So liver evaluation needs to be included in the follow-up workup of diabetes mellitus patients. Thank you so much.